The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
If I could subtitle this conference, I would call it what every developmental pediatrician wishes that every parent knew. And so I'm going to try to go through with you some of the right questions to ask regarding your child's medical workup, regarding therapies, and regarding some evaluations, and to review what I think commonly gets missed when kids get a diagnosis of autism. We're going to try to review a little bit about the current DSM-IV diagnostic criteria and what the new DSM-V criteria are that are going to be enacted in May of this year. We'll talk a little bit about medical workup, what some of the clues are that might indicate your child needs more testing, and some guidance, some advice about making sure you're getting the right therapies. So just to review where we're starting from, these are the current diagnostic criteria that are through the APA, the American Psychiatric Association, their diagnostic and statistical manual, and this is version 4, which will be in place until May of this year. And there are 3 main areas of impairment, which you're all probably very familiar with. The first is qualitative impairments in social interaction, and there are a number of symptoms that fall under this category. Those include things like marked impairment in the use of multiple nonverbal behaviors, which includes things like poor eye contact, not reading facial expressions, not reading body language, not using gestures like pointing and waving to have a social interaction. It also includes a failure to develop peer relationships appropriate to your developmental level, and it's important that this is developmental level, not chronologic age. So if your child is 4 years old, but is developmentally at a 2-year-old level, we'd expect peer relationships at the level of a 2-year-old, not a 4-year-old. There can be a lack of spontaneous seeking to share enjoyment or interest with others, and this is coming to share an experience, not just bringing a toy to a parent to have it opened or fixed. And there's a lack of this social or emotional reciprocity, which is the natural back and forth of human interaction. The second category is a qualitative impairment in communication, and that can include anything from just a delay in language to a total lack of development of spoken language. You can see impairments in conversation, so kids may have plenty of words or vocabulary but not be able to use those in a way to have conversation, not just to get needs met. There can be repetitive or stereotyped use of language, what we call scripting, or other unusual ways of using language. And a lack of spontaneous or very pretend play, make-believe play. The third category is restricted, repetitive, or stereotyped behaviors or interests, and that can include being obsessed or preoccupied with some unusual interest that's either abnormal in intensity or focus. There can be inflexible adherence to nonspecific and non-functional routines, such as lining up cars rather than using them in play. There can be stereotyped or repetitive motor mannerisms, so that can include things like hand flapping, finger flicking, toe walking, rocking back and forth. Or being preoccupied with parts of objects, so a real common example would be, spinning the wheels on a car rather than using that car in more pretend play. So the current diagnosis requires that you have at least 6 of those items, with at least 2 from the social section and at least one each from the communication and the repetitive behavior sections. So that's the current diagnostic criteria. And it also requires that these delays or abnormal types of functioning show up before age 3, either in your social interaction, your social language, or your symbolic or imaginative play. So this is in contrast to what the proposed criteria are in DSM-V. And I call them proposed because we haven't seen the final version, but the time for commenting on these is over, so I assume what we saw at the last revisions is what's probably going to be coming out in May. So now there are 4 categories, A, B, C, and D. In the beginning, you have to have all 3 in this first section. So it's no longer mixing and matching parts of criteria, you need all three in this area. And the first thing you'll notice that is different is they've now combined the social and the language piece together. So now the criteria is persistent deficits in social communication and social interaction across context. And that would include problems with your, again, the social and emotional reciprocity, which is the back and forth of conversation, the back and forth that's joint attention, which is sharing an experience with someone. So it needs to be deficits in the nonverbal communication behaviors, again, the eye contact, recognizing body language, recognizing facial expression, using gestures. And also deficits in developing and maintaining relationships, whether that's in play or making true friendships. The second section criteria is, again, the restricted and repetitive patterns of behavior or interests or activities. And there are 4 symptoms here, and you need to have at least 2 of the following. And that includes, again, the stereotyped or repetitive speech or motor movements or stereotyped ways that you use objects. It can include excessive adherence to the routines and rituals, again, lining up cars, doing things that are non-functional, but also being excessively resistant to change. Having highly fixated and restricted interests that are abnormal either in intensity or focus. And then a new criteria, which I'm very pleased is actually in here because many of your children, I'm sure, have this, which is sensory issues. So now in this category are things like under or over reactivity to sensory input or having an unusual interest in sensory aspects of the environment. So I think that's a very positive thing that was added to the criteria. Also, there's a little change in the age of onset. So they agree that symptoms must be present in early childhood, but there's now a caveat that the symptoms may not become fully manifest until the social demands exceed the child's capacities. And that would allow for a milder child to be recognized at a little older age. And then the 4th criteria is that the symptoms have to be impairing to the child's life. There will also now be 3 levels of severity, basically mild, moderate, and severe, which they are coding as requiring support, requiring substantial support, or requiring very substantial support. So the rationale that, for them changing from autism to autism spectrum disorders, which under this new rubric will eliminate PDD and eliminate Asperger's, which we'll talk a little bit more about that. But the rationale was that they felt that since autism is defined by a common set of behaviors, it was best to call it one single diagnostic category, autism spectrum disorders, and then adapt the diagnosis to the individual's clinical presentation by looking at more specific things like their verbal abilities, their severity of their symptoms, and whether they also had other features like intellectual disability. So the biggest changes are that 3 domains become 2. So instead of having a separate social category and a separate communication category, they're now combining the 2. And their rationale was that deficits in these 2 areas are inseparable, that delays in language are not unique or universal to autism, and that language delays influence the clinical presentation but don't define the diagnosis. They were also concerned that in DSM-IV there were multiple criteria that looked at the same symptom, and that would carry too much weight in the diagnosis and potentially overdiagnose children. And again, they retained the fixated interest and repetitive behavior category. So I think there are some, there are both benefits and downfalls to this new approach. Some of the potential benefits, we hope that there's better accuracy in diagnosis without sacrificing picking up all the kids who should be picked up, and that's the controversial part of the change. I do think combining the social and language together makes sense because some of the symptoms were really hard to put in the category. So, is eye contact a social skill or is it a language skill? I think it's both. But they had to be in one or the other in the previous criteria. Is imaginary play a social or a communication skill? I think it's both. So with this new diagnostic category and the new classification, combining the 2 seems to make some clinical sense to me. I also appreciate that the new diagnostic criteria allow that for milder children, we may not notice the symptoms until they're older, when they're actually in more social settings where it becomes apparent that they can no longer override the social challenges by just having good cognitive skills, for example. It's probably helpful to have a severity range. Every parent asks me, do I think their child's mild, moderate, or severe, where they are on that autism spectrum. So I think that will be helpful information to have. But I think there are a number of concerns, and many people in the community of people who care about children with autism have a number of concerns about these new diagnostic criteria. My biggest concern is I'm not sure kids who have Asperger's syndrome are going to fit, because they may be too mild to fit under the current recreation of the autism spectrum criteria. There's concern that the symptom list is too restrictive. For example, you now have to have all 3 symptoms in the social and communication listing of symptoms. You can't have some mixing and matching combination, and that might eliminate some children who may have 2 out of the 3, but not all 3. And in the old criteria, you could have some subset of symptoms, not all of them. And the biggest concern, and it's a very realistic concern, is this going to result in a loss of diagnosis? Because if that happens, then there might be loss of service, whether it's through school or private therapies, and there may be loss of insurance coverage if you're fortunate enough to have insurance that actually provides service and therapies for kids with autism, including those of you who have benefits through the military, through TRICARE, who have excellent benefits, for example, for ABA therapy. If you lose the diagnosis, will you then lose all those benefits? Now, there have been, before the criteria were finalized, there were some studies done, and I'll tell you what my concerns are about some of those. So the American Psychiatric Association did field testing, and they felt that based on the testing that they did, that there would not be any change in the number of patients receiving care for autism in treatment centers. And I think that's an important point, because maybe treatment center kids are different than kids seen out in the community. Then Autism Speaks in May of last year also did a field testing of 300 kids who were seen at 4 different pediatric autism clinics, and they felt that the majority of the children retained their diagnoses under the new criteria. But my concern is that these 2 studies may not be representative of what's seen out in the broader real world, that kids who are seen in treatment centers or tertiary care centers or autism clinics might be the more severe kids. Maybe that's why they ended up there. And I think the more severe kids are going to qualify fairly easily in the new criteria, but the milder kids may be left out. And it's the kids in the community-based settings who might have a broader range of presentation, including milder kids. The other concern I had is some of the field testing was done because this is the American Psychiatric Association, that they did a lot of testing with offices for psychiatrists and other mental health professionals, and not necessarily with pediatricians or developmental pediatricians and neurologists. And at least I know in my practice that the kids I refer to the psychiatric professionals or the mental health professionals are often the more severe children with more severe symptoms, or I wouldn't need to refer them. So again, I wonder if it's a skewed population that's been tested. So the big concern is that the more severely affected children will be less likely to lose their diagnosis with the new criteria, but the milder children may, and in my view, especially the children with Asperger's. There's a new study that provided little hope to me, which was, it was a study of over 4,000 children, which just got published last October, where they looked at children who under the old criteria had a diagnosis of pervasive developmental disorder, which by definition is a milder presentation on the autism spectrum. And they looked at previously collected data, both using parent questionnaire and clinicians' observations. And they found that most of the children who had a diagnosis of PDD under DSM-IV would retain an autism diagnosis in DSM-V. And the hopeful piece of that is they were looking at milder diagnoses and still found that kids retained their diagnosis. Now, there's also a new diagnostic category in DSM-V which was not in DSM-IV. It's called social communication disorder. And it has 2 diagnostic criteria. One is persistent difficulties in the pragmatic or social aspects of communication, both verbal and nonverbal, and also persistent difficulties in acquiring and using spoken language, written language, or other language modalities like sign language. And this may capture some of the kids who no longer fall under the autism spectrum disorder. And the real question is, what level of services will be able to be obtained with this diagnosis? Will insurance recognize it as a legitimate disorder to provide therapies? Will schools recognize it to provide therapies? I'm not sure what's going to happen. I think the bottom line is there are studies out, but I think we won't know what's going to happen until we see some real-life evidence of once these criteria go into effect. In May of this year, will school systems try to undiagnose children or re-diagnose children with the new criteria? Will insurance companies require reevaluations? I think we really don't know what's going to happen. I do have concerns about kids being penalized by having made enough progress that now they're so mild that they won't be called being on the autism spectrum, as opposed to saying they have residual symptoms still remaining of their autism spectrum diagnosis, and therefore still require the school system to provide adequate supports. So I'm not quite sure how we're going to get around this. Maybe that we have to see how it falls out and then sort of all rise up and protest if too many kids are losing their diagnosis. One strategy I'm thinking about, and I don't know if this will work for schools, is that if a child loses their autism spectrum diagnosis, there is another category, educational diagnostic category called other health impaired, which we've used, for example, kids with attention deficit disorder who have enough symptoms that they actually need an IEP. And I'm wondering if we might be able to, let's say, call some kids social communication disorder and put that under other health impaired, and then still advocate for appropriate speech and social supports in order to provide the free and appropriate education that they're entitled to. So I think there are a lot of legitimate concerns. There was a lot of good things in the new criteria, but also a lot of legitimate concerns, and I think we're going to have to wait and see what happens and then respond, unfortunately. So that's basically what I wanted to tell you about the new criteria, and I want to shift now into what I think are some of the pitfalls that happen when you get an autism diagnosis, some of the things that end up being missed, and give you some clues to hopefully help you make sure you're not missing anything in your children. So the biggest problem that I tend to see when kids get an autism diagnosis is professionals, including us as pediatricians and physicians, sometimes stop thinking once a child gets an autism diagnosis. And then what can happen after that is that everything that happens in that child's life is just their autism. Right? And so that can be a problem, because your child may have constipation, and the response will be, well, autistic kids have constipation. Your child may have a behavior issue, and they may say, well, autistic kids have behavioral issues. And I would propose that children with autism really need a thoughtful diagnosis and approach about their medical issues and their behavior issues and coexisting diagnoses, just like children who don't have autism, because not everything is just autism. And the challenge can be not that physicians don't want to be able to help with these issues, but primary care physicians really vary in their knowledge about autism and about their awareness of services in the community and the school system. And there's a very real problem in their primary care practice with time constraints. If you have 40 kids with the flu throwing up in your waiting room, you can't take an hour to assess a child with autism adequately. So you often need to be referred out, and if your physician does not volunteer that, then I would suggest you consider requesting a referral to a developmental pediatrician or other appropriate professional in your area to get a more thorough assessment. And today I'm going to try to give you some clues and guidance about some questions to ask and some things to look for, so you'll know whether you might need to request a referral for more assessment for your child. So one of the things that still surprisingly is not always adequately addressed in children who come to see me is making sure they don't have a hearing loss. And the reason that's important is that severe or profound hearing loss can look like autism, but also can coexist with autism, and that might be a potentially treatable aspect of your child's condition. It is not enough to just have a newborn screen, because you can have a perfectly normal newborn screen and acquire a hearing loss, especially over the first 3 years of life. And many parents will tell me that they're sure their child can hear, and what we can know for sure fairly easily is that the child is not deaf, because they're responding to sounds in their environment. But what we don't know without a hearing test is whether the child is hearing at the frequencies at which speech is spoken, and that's a much narrower and lower decibel level of speech. So there is some behavioral testing that most kids can cooperate with called visual reinforcement audiometry, which I'm going to explain to you. And if your child really is not able to cooperate, there's a test called brainstem evoked response testing, where the child is sedated and really looks at the brain's response to sound. But most kids don't need to go to that point. So visual reinforcement audiometry is done in a sound field, which means sitting in a soundproof booth. They don't need to have headphones on. And basically your child would be sitting potentially in your lap, and in front of them would be two speakers, one to the right of them and one to the left of them. And on top of the speakers would be some visual reinforcer, for example, a bear that would light up and play the drum. And the way they would condition the child in the beginning is to have a sound come out of one of the speakers and have the bear light up and play the drum at the same time, which conditions the child to look at one speaker or the other. And once the child has figured that out, then they would present the sound first, wait till the child looked, and then reinforce the looking by making the bear light up and play the drum. And then what they would do is gradually lower the decibel level of the sound and see which, how low a sound the child can recognize by looking to the right or the left speaker. And then they can determine if the child is hearing at the frequencies at which speech is spoken. And it's important to know that you don't need to know which ear is hearing, because if they're not wearing headphones, you don't know if they're using one or both ears to hear the sound, but you only need one ear to hear well enough to develop language. You can be completely deaf in one ear and still develop language if the other ear is hearing well. You need both ears to localize where the sounds are coming from, but not to develop language. So this is a good adequate hearing test for most kids, and kids who are developmentally at an age 6 or 7 months where they can really lateralize where sounds are coming from, if they're not too sensory sensitive to being in the soundproof booth, can cooperate with this testing. My personal pet peeve is that people don't often take the nonverbal autistic child seriously enough in terms of looking for reasons why the child is nonverbal. So the most common comments I'll hear why people don't get more assessment is that they've been told, well, he's not talking because he's autistic, or my personal favorite, she doesn't need speech therapy yet because she's not talking. And I would contend that who needs speech therapy more than a child who's not talking? And the other important distinction to make is that talking and communicating are not the same thing. So nonverbal children need a way to communicate. Otherwise, as many of you have probably seen, if they don't have words, they're going to use their behavior to communicate, or they're going to withdraw and not even attempt. So what are the things to think about if you have a nonverbal child? And I think about this in kids who are cognitively high enough that I expect that they should be speaking, and yet they're not. So the two main things I would think about is hearing loss. But the other thing that I find gets very commonly missed is something called verbal apraxia. And praxis basically means planned movement. So apraxia means a problem with the planned or automatic movement of your mouth. So apraxia is a motor speech disorder that affects the planning and production of movements of the lips, the jaw, the tongue, and the palate in order for you to produce intelligible speech. And if you really think about it, it's a true miracle that any of us can speak, not just in words, but actually in paragraphs and multiple paragraphs, because you have to move all the parts of your mouth and the lips and the jaw so quickly to make multiple different sounds come out. So even if you think about something as simple as saying the word mama, you have to close your jaw and press your lips together and force a sound past your lips, and then open your jaw, jop it open, make a new sound come out, then put it all back together, compress the lips again. Repeat that whole sequence just to make the word mama come out, much less a whole string of words, a sentence, a paragraph. And this gets very commonly missed. And this can really affect your performance in other therapies. So if you're an ABA and the therapist is saying, say ball, and you know ball, but you cannot make your mouth say it, you're not going to be able to perform. So what are the clues that you can look for to see if perhaps your child may have an apraxia that needs further development, further assessment? And the first thing is what they call visible groping, which is a child who may be really doing trial and error to get the correct sound to come out. And some of the kids will really contort their whole face or sometimes their whole body, just really trying to force the right sound out in the right way. These can be kids who have trouble, they can make individual sounds but have a really hard time putting together an intelligible string of words. I find this to be a very helpful clue, you may have a child who can say a word correctly once and then never say it again, or maybe weeks between the times you hear that actual word being spoken in an intelligible way. And that can be a good clue, because what actually happened is the child really doesn't know how to plan the process for making that word, but sometimes all the stars will align and that word came out easily and fluently, and then everybody gets very excited and puts an immediate demand on the child to say it again, and then anxiety is layered on top of the motor planning problem, and it's impossible to repeat it. So if you have a child who can say words clearly sometimes and not another, I would wonder about apraxia. Also, these can sometimes be kids who are much clearer when they speak spontaneously than when they're in a demand setting. And again, I think it's because anxiety makes everything worse when there's demand. These can be kids who have a limited repertoire of consonant sounds, so they might use ba or da for everything. Or they might have a very limited repertoire of vowel sounds. And what I've also noticed clinically is sometimes these are kids who are not making eye contact, not necessarily because they don't know how to make it, but because they really need to watch your mouth to see if they can figure out how you actually made that sound come out so they can try to imitate it. And the reason you want to not miss this is because there is some very specific therapy that can help apraxia that is not routinely offered if you don't ask for it. So if you think your child has apraxia, you might want to request an evaluation by a speech pathologist who has some expertise in the area of apraxia. And ideally, you would want an evaluation by a speech pathologist who's trained in something called prompt therapy. I'm going to describe what that is for you. So prompt therapy is just an acronym that stands for Prompts for Restructuring Oral Motor Phonetic Targets. And what that basically means is that the therapist would use lots of types of sensory input, including very specific positioning of hands inside or outside the mouth, to teach the child how to move their mouth to make speech come out, to help it become more automatic. And this is different from what we would call prompting in ABA, where you're giving a verbal prompt or a visual cue to help a child speak. This is actually very hands-on, very sensory, to teach kids how to develop automaticity around their motor movements in their mouth. And the challenge is it's not usually available through school because it requires a year-long, very specific training to become prompt trained. So you most likely have to go privately to look for a therapist who has this training, and you would want to ask for a prompt trained or a prompt certified speech pathologist. And I would say this is the best treatment that I've found for apraxia. I have kids I do not think would be talking without it. But it's also important to remember that prompt therapy takes time. I have a number of kids in my practice whose autism got better before their apraxia. So the challenge is, while you have apraxia, you still can't produce intelligible speech, and children without speech who have apraxia need a way to communicate. So for those kids, it's really important to request evaluation and therapy about alternative modes of communication, such as augmentative communication. And that can be something as simple as picture communication symbols to something more sophisticated like augmentative communication devices. And the most popular device right now is the iPad. It has excellent software. I just listed a couple for you, Touch Chat, and the more broad spectrum program is Proloquo to Go. It has excellent graphics. It's user-friendly. The kids seem to very intuitively know how to use it. And even kids who weren't interested in other older forms of augmentative communication devices often will take to the iPad. The challenge with the iPad is schools may not pay for it like they will pay for other AugCom devices. And I think this is a case of the technology outpacing the rules from the school, because the school is allowed to buy your child a communication device. They're not allowed to buy your child a home computer that other people could be using. But I think the rules will catch up with the technology because the iPad is so much cheaper than the older devices. For your kids who are throwers or who are destructive, the iPad is less sturdy than other devices, so it's not always appropriate. And the one advice I would suggest is that if you get an iPad for your child and you want them to use it for communication, don't let them use it for YouTube or other things, because once they discover YouTube is on there, they're going to just want to play, and they're not going to want to use the device to communicate. So let them do those things on a different computer and use the iPad or the device just for communication. A number of parents have raised concern to me that they're afraid if they give their child a device to speak, they'll be less motivated to speak. And that's really a myth. Using a device will not prevent a child from developing speech. One of my speech pathologists said, we put a lot of limitations on how kids can communicate, but that we would never put on ourselves. So we would never tell any one of us, you can only talk to me, and you cannot text me, you cannot email me, you cannot write me a note, you cannot point. We need to give these kids all the ways that are potentially helpful for them to communicate. And speaking is easier, so once they can speak, they will not want to or need to use the device. The other caveat I would just mention is that children who often have motor planning problems around their mouth often have motor planning problems with their hands. So for those kids, sign language would not be a good choice because then they might not be able to use their hands well to make signs. So I would think about motor apraxias if a child is not able to make an accurate sign or uses one sign like more, which is very simple, and uses that for everything. I want to shift gears a little bit and talk about developmental regression, because this is something that also doesn't necessarily get thought about in depth enough for kids on the spectrum. It is never normal to have a developmental regression, but it's fairly common to find in kids with a history of autism, particularly in that 12 to 24 month period of life. But things that would make you think regression is not just autism would be kids whose regression started after that 24 months. So kids who regress after 2 years, or especially if they regress after 3 years. That may not be typical for autism. In addition, children who have more than one regression, that is definitely not typical for autism. If you regress in that 12 to 24 month period and you recover and you're doing better and you regress again, that's not normal. And also if you tend to regress with illness or with fasting, especially if your child gets unusually lethargic or vomits every single time they have an illness, even if it's not a GI illness, those can all be clues to potentially having a metabolic or a mitochondrial disorder, which is potentially amenable to treatment. So if your child has any of these sort of unusual history of regressions, then I would suggest you might need more of a workup, which if your pediatrician is not skilled to do that, then a neurologist or a genetic or metabolic specialist may be the right person to do it, and I'd suggest you ask for a referral. Because there are potential treatments to help the mitochondria work better, and that can include changing your diet or providing nutritional supplements, which in the traditional world they would call a mitochondrial cocktail of nutrients. Then to finish up, I want to talk a little bit about a couple things about therapies that you may be getting through the school system that maybe help you get a little more bang for your buck out of the therapies. So I spend most of my day doing biomedical treatments, dietary and nutritional treatments, but it's also really important to not neglect therapies and educational supports. So to me, the biomedical is helping the child's body from the inside out, but school and therapies are helping from the outside in. So it's really important to have a good comprehensive evaluation and then individualize the therapy program for your child, which may be very different from his classmate or his neighbor's program. And then it's very easy to get used to the current therapies you have, but it's important to reassess and adjust the therapies over time because the child's needs may require different types of therapies as they progress. So I want to say a few words about speech therapy. Unfortunately, it's rare to get adequate therapy from school alone. I think not because they don't have a desire to provide it, but they just don't have enough funding or a therapist to give every child all that they need. So one of the main recommendations I make is when it's affordable to add private speech therapy. But to maximize what you're getting at school, I would say if your child has a significant speech delay, I would really advocate for individual therapy initially, because what I find is oftentimes school will give group therapy, and they'll often justify that by saying your child can then benefit from the social piece of being in a group. And dyads, which is 2 kids together or small groups, can often be helpful for pragmatics and for generalizing your individually learned skills. But that's only helpful when the child is at the appropriate level of skill and awareness to benefit from the group. So if you have a more severely affected child who's not paying attention to the social cues or to other children, if they're getting 30 minutes of group therapy, they may only really be getting therapy for the 10 minutes when the therapist is focused on your specific child. So Groups are often helpful, but if you're significantly affected, I'd also advocate for individual therapy. If your child has APRAXIA or other needs where an augmentative communication device might be helpful, most schools or districts will have a team that can evaluate for that. My pet peeve about this is they'll often get an evaluation, get a device, and then there's no therapy to help the child learn to use the device. And it often becomes a device that's used for making choices, like what drink do you want to have at snack time. And I think the real point of the device is not to be able to make choices, but to become a better communicator, and that really requires therapists. So I would advocate for therapists to help the child learn to use the device, not just the teacher in the classroom. Unfortunately, sometimes you have to go privately for that as well. And then I just want to say a few words about occupational therapy. As I'm sure all of you know, many children with autism will have sensory processing issues, being over or under responsive to certain senses or seeking out certain sensory input. And clearly, if you cannot stay regulated in terms of your sensory system, it can affect your ability to access therapies and to access education. And this can be remediated either through direct therapy from an occupational therapist or what's called sensory diets. And a sensory diet is basically feeding the child's nervous system with the appropriate input they need to stay regulated. It's really important to have a sensory diet at home and at school so you can carry over what the therapist is doing in that 1 hour per week of therapy. I think where kids are not getting as much therapy as they need is that it's really important to have what I would call a proactive sensory diet, which means giving you the sensory input before it's evident that you need it and not just reacting after the child is dysregulated. So really common reactive strategies, let's say your child is in class and it's very hyperactive or starts behaviorally acting out. A reactive strategy would be to remove the child from the classroom, go walk in the hall, go to the sensory room, to swing, to jump on the tramp, to do something to re-regulate, and then come back to the class. And the problem with that is your child's removed from the classroom and is also missing out on educational time. So I think a proactive sensory diet is much more helpful, so giving it before it looks like you need it. And I would say that a sensory diet, to me, is very directly analogous to, feeding yourself food. You don't wait every day, skip breakfast, and realize at 11 o'clock you're cranky and irritable and inattentive and realize you need to eat. You pretty quickly realize that if you eat breakfast at 8 o'clock, you will not become irritable and cranky and inattentive at 11 o'clock. So children with sensory issues, it doesn't make sense to me that we wait till they dysregulate and then give them input, if that's pretty predictable. And instead, you can give input at the beginning of the day, for example, to keep the child regulated throughout the day. And they may need input several times throughout the day to keep themselves regulated. And I think if you're requesting this, it's really important to get the sensory diet into the IEP so that you can have some accountability that it's getting done. I think the real key is to get this implemented is to make sure that the sensory diet is doable for the school system, because they often really want to do it, but they may not have the staffing to have someone take your child out of the classroom to the sensory room. And it's not fair to the rest of the children if the aide leaves the class with one child and leaves the rest of the children with less support. So it's really, if you have a good creative occupational therapist, whether through the school or privately, they can often come up with very helpful things to do within the classroom. So for example, I had one child who people thought had ADHD because she kept putting her feet up on the desk and pressing very hard into her desk and pulling her shoelaces to the point where they broke. And she was clearly seeking what we would call proprioceptive or pressure input to the bottoms of her feet to keep herself well regulated. And what our OT came up with was to take those stretchy TheraBands that you use for resistance and exercises and tied it around the base of the legs of her desk. And now she could put her feet under the desk, press against the bands, and get as much resistance as she needed. It wasn't distracting anybody because it was under the desk. It required no aid or therapist to do it. She could regulate herself throughout the day. Other kinds of input that can be similar in the classroom, high enough functioning kids can be taught to do wall push-ups. They can push heavy racks of books across the room or carry heavy books or sink into a beanbag chair. These are all things that don't require leaving the classroom or much staff attention to do. Other kids may benefit from sitting on a therapy ball or having special seat cushions. So the key, I think, is really to make this easy for the school to do, and I think it benefits everybody if your child stays regulated. And then just to finish up, just some practical challenges that I know patients of mine have come across. I think it's ideal to have a developmental pediatrician or another clinician coordinating your child's medical workup, medication, supplement management, guiding you about school and therapy, helping you coordinate physicians and therapists to work together. But that's not always possible. Sometimes, depending on where you live, there may not be an appropriate clinician who understands traditional management of children with autism or understands the functional medicine biomedical treatments. And even if there is, there are financial issues because particularly the functional medicine approach, the diet and nutrition is often not covered by insurance. And to case manage a child with autism and coordinate all the therapies is very time-consuming, and unfortunately insurances do not reimburse well for case management. So if you end up having to be your own case manager, as parents often do, I have a few suggestions for you about that. The first thing to do would be to seek out the best available clinicians locally to you. In some cases that may be a pediatrician or a developmental pediatrician. Other places it may be a neurologist with an interest or a psychiatrist with an interest. And the best places to go are other parents. So the local Autism Society chapter may be a good resource. And also therapists often know who the good physicians are in your area. I would also say those of you who are doing biomedical treatments, I would say you don't necessarily have to have your traditional doctors or specialists believe in the value of your alternative treatments. What I mostly want from the traditional clinicians is someone to give me advice about whether anything I'm proposing might be harmful from their traditional perspective. So I just want someone who is open-minded enough to really listen, and even if they don't believe my treatment is helpful, to at least be willing to advise me of whether they think there's anything unsafe. For example, an interaction between a medication and a supplement. And I think if you frame your questions to these clinicians in a way that shows you're asking it because you're concerned about safety, even if they're not believers, you might get a more thoughtful response. Other just very practical things, I think when you get any testing done, whether it's blood, urine, or stool testing, get a copy for your own records. Same thing with hearing tests, EEGs, MRIs. Most of us don't need to see the actual MRI or the actual EEG, but it's helpful to see the written report that summarizes the findings. If you see a specialist, a neurologist, a GI doctor, a geneticist, again, get copies because it's going to be really helpful for your clinician who's evaluating your child to see those, but it's often hard to get those results later on, especially if you've been evaluated by a hospital. You have to go through medical records, and that can be a not very efficient process. So get all the results so that you have them for your own files. Keep an up-to-date folder. And then I think when you see a specialist, bring copies for that physician to keep because they're much more likely to look at the results and put them in good context to give you better feedback if they have them at the initial meeting than if they get them a month later after they've seen your child. In terms of therapies, I do some of the guidelines I talked about earlier. If you have in terms of speech therapy, if you have signs of APRAXIA, I'd recommend looking for a prompt-trained therapist, and if necessary, looking into getting an augmentative communication device evaluation. And for occupational therapy, I would recommend ensuring that you have a proactive sensory diet at school, not just reactive, and also that you're given sensory things that you can do at home. And then most importantly, I'd say just get as much information as you can from trusted sources so that you have enough information to make informed decisions and choices about your child. And then you have to trust your instincts as a parent because you know your child and your family's needs better than anyone else who will ever see your child. So in summary, I would recommend that you continually reevaluate your child's needs and adapt or change his or her program as needed. And then I would say also have hope. I mean, those people who don't believe in sort of a combined traditional and biomedical approach will say that we are giving people false hope. And I would say how I describe myself to my patients is that I'm a realistic optimist because I'm not God and I don't know what the outcome's going to be. But I prefer to assume that all children can be helped to some degree until proven otherwise. And so I would say that having realistic optimism is not the same thing as being given false hope. So I would just suggest that you always have hope. So that concludes the formal part of my talk. So I will now look here and see what questions have come through, see if I can answer some of your questions in the remaining time that we have left?
Yes, Dr. Compart, they're in there under the chat. The questions have been coming in throughout the talk, so there's a big list of them. But you can just start going through those in the chat, and I'll keep popping them in there for you.
Okay. Let's see. Can I please repeat the name of the gluten-free casein-free book? My son has many food allergies and is on the GFCF diet. There are a number of books. Our book is the kid-friendly gluten-free. You think I know the title off the top of my head? The kid-friendly ADHD and Autism Cookbook. There are also some good books out by Lisa Lewis on special diets for special kids. This question also has hope for allergy discussion as well. I'm not sure what the question is. Food sensitivities are different than food allergies. There's good discussion in the book that I co-wrote with Dana Lake about this. That's probably more than we can get into at this particular discussion. One question is, how do the criteria for PDD-NOS change from DSM-IV to DSM-V? The change is there is no PDD diagnosis in DSM-V. It's completely eliminated and will be sort of subsumed under autism spectrum disorders, mild, moderate, or severe. So probably the kids who currently have PDD, if they retain their diagnosis, would be autism spectrum disorders and probably the milder version, requiring support. Let's see. One question is, a parent in my support group is upset that autism may be considered somatic symptom disorder, which is a mental illness. He's concerned that stigma attached to mental illness would limit opportunities. Should he be concerned? I'm not familiar with that somatic symptom disorder diagnosis, so it's hard to say whether that will end up being a problem. I think that's not a very common diagnosis, so I don't see a lot of kids being shifted from autism spectrum disorder to a more mental health kind of disorder. I think they're probably going to stay in the sort of developmental disorder category, but what might happen is kids who currently have an autism spectrum disorder will now be called speech-language impairment, for example. And while that will get you service, it will not necessarily get you the intensity of either class placement or intensity of speech-language service. So I think what's really going to happen is that kids get a lesser developmental disorder diagnosis and not shifted over to some mental health disorder, if I had to predict. Okay, so next question. If kids, I mentioned that maybe one way we can get around this is to code kids as other health impaired. The question is, will the school want the kids to take medications for that before the IEP goes ahead? And let me just clarify, when I said other health impaired, it does not mean you have to say the child has ADHD. That's just, ADHD is one of the diagnoses that could fall under other health impaired. Other medical conditions could fall under that too. So I was not suggesting that we should call the kids ADHD. I'm just suggesting we might be able to come up with a different label like social communication disorder and then put that in the diagnostic category for school of other health impaired. I would also say that even if your child is ADHD, the school is not allowed to tell you that they need medication. That is not an educational decision. That is a medical decision, whether kids need medication. So schools may want your child medicated, but they cannot require that your child take medications, and it certainly cannot be a criteria for an IEP that your child must go on medication. Okay, the next question is regarding kids that are considered to be Asperger's. How will this be defined after this new criteria? What is going to be their diagnosis? That's my biggest concern, is where are these kids going to fit? I think some of them will fit under autism spectrum disorders if they have enough language and social dysfunction that they are significantly affected enough. They'll just be called autism spectrum disorder instead of Asperger's. But my fear is the kids who really are high enough functioning, that they're cognitively high, that they have plenty of language, they can actually have a conversation, but really it's all about the pragmatics, that they don't know how to socially interact or have appropriate kinds of conversation. I'm afraid that they may not be covered under this autism spectrum label, and they may also be too high functioning to fall under the social communication disorder label. So I do think, even though Asperger's is very similar to autism in many ways. There are some qualitative differences that make them sort of unique in sort of their strengths, but also in their support needs. And I think that's the group we're going to have to really keep our most focus on to see if those kids will still have a diagnosis and how we're going to provide support for them. So how do you lose a diagnosis? This is probably going to happen if school systems reevaluate your child, as part of either their every 3-year evaluation, or I don't know if school systems are going to intentionally speed up the reassessment time frame to unqualified kids. So it'll be about reassessing children just like when they got their initial assessment, looking at their speech and their language and their occupational therapy needs and all, doing diagnostic questionnaires and interacting with the kids and really seeing if they meet the new criteria. And if they no longer meet the new criteria, the challenge is with the change in criteria, the children may look exactly the same on the day before the new criteria as they do on the day after the new criteria, but they just may not, they may be called something different. And that's what I mean by losing a diagnosis. Let's see. What other questions? Yeah, this question, what tools and tests will be used to find the new diagnostic criteria? Because right now there's one test that's used a lot called the ADOS, which is a very structured communication questionnaire. And I don't know if they're going to have to redefine all those testing questionnaires, too, to meet the new criteria. I'm not quite sure how that's all going to work out. Let's see. Okay, another question. My son has high-functioning autism. He's 9 years old, and right now his main problems revolve only on social skills. Is he in danger of losing his previous diagnosis? I think potentially, unfortunately, yes, because now the new criteria require that you meet, all 3 criteria in the social and communication areas, as opposed to having some mix-and-match combination of social and language. And that's where I hope if kids lose the autism diagnosis, that perhaps the social communication disorder diagnosis will pick up those kids. And then the question is how we code them for school. And this, the real disappointing potential outcome of all this re-diagnosis is that you hate to see kids penalized for having made progress and for losing some of their symptoms, but still remaining on the spectrum. So it would be really nice if we could say, yes, he's made progress. What he has now are residual symptoms that are left over from his autism diagnosis, so that, if you saw this child today for the first time, you wouldn't call him autism because he has made so much progress. But if you know the whole history of where he started from, it's very clear that this remaining symptom is left over from the autism diagnosis. And it would be very practical to approach things that way, and it would be a way to get kids to keep their services, but I think it's not going to fit into the criteria. And that's the real potential danger of the change in the diagnostic criteria. Let's see. What other questions? Okay, next question is, how do you get a child diagnosed when they look normal, but have the loud voice, zoned in on their interests, unrelenting in their desires, only see school as school and home as home, and won't combine the 2 ideas when it comes to homework, questions about school, teacher requests? And I think you really need a good diagnostician, whether that's a developmental pediatrician or a psychologist with expertise, because not everything that looks like autism is autism, or some kids are not really straightforward. I always say the kids do not read the textbook, and so they have whatever symptoms they want to have, and it's up to us as good listeners and good observers and good diagnosticians to really try to put the pieces together and see what the best descriptor is for that child's particular presentation. And then no matter what the label is, how are we going to help support the child with education, with therapy, with biomedical treatments to make them have less of whatever their problem is and to give them the best chance at best outcome. So regardless of the label, getting your kid diagnosed or labeled really requires a good, thoughtful diagnostician. Sometimes you can get that through the school system, and sometimes you really need to go, often you need to go privately, because someone has no vested interest in what the outcome is. Would I address the fact that most speech therapy is geared towards stroke and brain trauma patients and not for kids who lack language to begin with? and how trying to reestablish pathways to a speech center in stroke patients makes this type of speech therapy ineffective for nonverbal kids. I'm not quite sure if the question is about insurance or about therapy. From an insurance perspective, sometimes insurance companies won't want to pay for habilitative therapy versus rehabilitative therapy. So sometimes they'll only pay if you had some event like a stroke or a brain injury, and then the speech therapy is geared toward rehabilitating you back to a previous level of function. And they'll pay for that, but they won't necessarily pay for habilitative, which means you have a developmental disorder that you might have been born with or regressed into, like autism. They often will not pay for that kind of therapy. So that is a problem. If your child is regressed, you can sometimes make a case for the therapy is now rehabilitative to bring them back to a level of pre-regression function and better. And then the speech therapies for kids with adults with strokes is very different from the type of speech therapy that would be provided to a child with autism, whether verbal or nonverbal. And so pediatric speech therapists are differently trained than the adult therapists. Let's see. Okay, the majority of my students have been diagnosed with PDD-NOS. Will they have to be reevaluated, or will progress notes be sufficient to continue their services? I don't know what the schools are going to be requiring for kids to maintain their label or to be given a new diagnosis. I don't know that that's clear yet. Let's see. Someone did make a point with regards to the iPad. There are a number of cases that work well to prevent damage. Yes, that's true. There are more and more coming out that some that can, withstand a 6-foot drop of the case. So I think that's a good point. I'm glad someone brought that up. Okay. Also, someone said with respect to YouTube, you can take that app off of the iPad. So thank you to the person who is pointing this out. Really appreciate that. He also points out you can use parental controls and restrictions with a password to control the internet access. I think all that's true. I think it's probably easiest for the child never to know that that's potentially on there, because then they can get very insistent on looking for it because they've known at some point that it was on there. So I think it's a good point. I think it also is easier if they just never realize they can access through the iPad some of those things. Let's see. One question is, does a tuberous sclerosis diagnosis along with severe autism have any impact on therapy and medications, in my opinion? I think it depends on what the complications of that particular child's tuberous sclerosis is. Do they have actual malformations in their brain that might make some things more fixed deficits than amenable to treatment? But even kids who have something, either genetically or a brain malformation, I think they can also coexisting have abnormal biochemistry, food sensitivities, and things like that. So I always look for the treatable components. Even if I can't make the genetic diagnosis, say the tuberous sclerosis, go away, there may be several aspects of that child's disorder that are treatable. Okay, until what point is it recommended to have a developmental pediatrician? For example, is it up just until the child is 5 years old and after that they get a neurologist? Developmental pediatricians, we see kids for broad spectrum of age range. Many will see kids up to 18 to 21. Some will see kids even older. So there's no cutoff point exactly at which a developmental pediatrician stops seeing a child and switches over to a neurologist. Can I explain the difference between dyspraxia and apraxia? I think they're pretty much the same thing. Apraxia is probably a little bit more of the severe form, and sometimes people will say dyspraxia when it's not quite as severe. But in essence, they're referring to the same thing, a motor planning problem.